So I believe we can start the talk. So I'm pleased to announce Sokleng, our Dr. Sokleng, our interventionist consultant. And thank you, Lang, for agreeing to give this presentation. I think it will be really valuable for our team to have another perspective from interventionists.
Okay, perfect. Thank you, everyone. Thank you for the opportunity to present in this forum. So I believe I've been asked to talk about percutaneous and hybrid interventions for hypoplastic left heart. I hope that you find it as interesting as I have, sort of reading around the subjects to prepare this presentation. So these are the objectives. I like to look at percutaneous interventions in hypoplastic left heart as those that are innovative versus those that are supportive, and I'll go through that in more detail later. A bit more focus on fetal cardiac intervention, which I think we don't really come across in our day-to-day life at present, but potential an intervention that could improve outcomes of hypoplastic left heart. Hybrid stage 1 procedures, and I'll finish with just a few examples of supportive interventions in hypoplas. So let me just set the scene. Sorry, I'm supposed to scroll this as well. Okay. So let me just set the scene by looking at the number of operations and interventions required in patients with hypoplastic left heart over a lifetime and some of the surgical outcomes. So as we all know, hypoplastic left heart is complex. It's characterized by variable hypoplasia of the left-sided cardiac structures, essentially producing a left heart that's insufficient to support the systemic circulation. So the timeline for a patient with hypoplas can really be thought of as an extension from fetal diagnosis onwards. Treatment generally begins soon after birth, and the conventional pathway, as we all know, is the Norwood stage palliation. The first procedure is generally undertaken within the first week of life. By the time they're discharged, they're usually about a month old. Then they're back at about 4 to 6 months of life for their bidirectional gland. And then they have on-time completion at 3 to 5 years of life. Now, a more recent alternative is the hybrid procedure, followed by a comprehensive stage 2. And of course, within that pathway, patients would have at least one, if not several, catheter interventions. Many patients we see start to get medical problems in their late adolescence. And the first cohorts of hypoplas spontan have reached adult services, and they're actually beset with significant cardiovascular symptoms and limitations. So, not a cardiac lesion that you want to have if you were going to have congenital heart disease. So what about the surgical outcomes? So we know that the Norwood palliation was first described in 1983, and since then, there have been major advances in not just the surgical techniques, which I'm sure Ramesh will go through next week as he goes through the surgical procedures. And there's also significant advances in post-operative management of these patients. It is still recognized as the most technically challenging operation in Norwood stage 1, and there have been numerous publications documenting the outcomes so far. So this is one of the very first multi-center data that came out in the 1990s. This is data from the Congenital Heart Surgeons Society. 710 units done around 1994 to 2000. So you can see that 1 year survival is pretty dismal at 60%, and 50% of them complete fontan, and there's significant mortality and morbidity surrounding the first stage of the procedure. 10 years later, in New England Journal of Medicine, this is the seminal paper that I think you all be familiar with. This is the single ventricle randomization trial from the Pediatric Heart Network across 15 North American centers. And just to bear in mind, these are really high volume centers, and they're considered to be experts in managing hypoplastic left heart. And you would have thought or expect results to be much, much better. However, the primary objective of this paper was this study was to randomize patients to BT shunt and Sano shunt. And the results did show a 1 year transplant-free survival advantage of the Sano compared to the BT shunt. However, if you look at the whole cohort, the overall survival curve could almost be superimposed on the results that were shown in the earlier slide from the CHSS database, where there's significant mortality, overall of 31% death or transplant by a year post the initial procedure, whether Sano or whether BT shunt. And the interstage mortality remains unchanged, around 12%. This is a follow-on study published in Circ of the same cohort at 6 years of life. So the assigned shunt groups did not really differ in transplant-free survival at that time, and it was around 64% in the Sano group versus 59% in the BT shunt group. So overall, 60% survival. And in the period, so that's the first graph, as you can see, the Kaplan-Meier curve and the p-value that's 0.13. And then on the other diagram, you can see that in the period from Norwood to 6 years of age, at least or more than half of the patients would have had one catheter intervention in that short period. And this is not including diagnostic procedures. So these were procedures for balloon angioplasty, stenting of the shunts or pulmonary arteries, coiling of aortopulmonary collaterals, and veno-venous collaterals. And if we put aside even all this sobering data on mortality, there are important morbidities throughout the life of these patients that affect not only the individual, but the family and the community. And this puts a significant burden on healthcare resources. So there's neurologic and developmental morbidity. Patients with Norwood palliation are known to have lower IQ than general population. They have abnormalities in speech and language, poor adaptive behavior, they have feeding issues, and they fail to grow. There's emotional and behavioral dysfunction, low self-esteem, lots of psychosocial issues. And from data from the smaller cohorts of the adult Fontan patients, you see a cascade of end organ morbidities, including hepatic problems, lymphatic disorders, PLE, plastic bronchitis, renal insufficiency, arrhythmias, and thromboembolic complications. So I hope that would sort of is kind of a primer for us to think that there's actually a lot of work and a lot of research and a lot of innovation that can be done in this patient group to improve, if not change, the outcomes. So for the purpose of this talk, I'd just like to group the interventions into two broad categories. So one that I think of as innovative and the other supportive. Of course, I think there's never a clear distinction between the two in that you can always improve on equipment or techniques, even in those procedures that's been established for decades long. So by innovation, I mean more recent treatments that has the potential to improve outcomes or quality of life, so such as fetal intervention, the more recent hybrid procedure, and lately some case reports and series publishing transcatheter Fontan completion. And by supportive, I mean those interventions that are complementary to the conventional surgical pathways, such as treating residual lesions, opening up the atrial septum, closure of Fontan fenestration. So I'm going to start with fetal cardiac intervention. What then is the rationale for fetal intervention? So I think the rationale is really to improve the hemodynamics in fetal life such that it could alter the fetal cardiac development sufficiently to change the postnatal outcome. So turning someone who's going into or evolving into hypoplastic left heart syndrome to someone who has the potential for BIV repair when they're born. And in very dire circumstances, fetal cardiac interventions aim to avert intrauterine death to allow survival until a full spectrum of postnatal treatments are available. So fetal interventions at the moment are really applicable only to a subset of lesions that develop later in gestation, so usually in the second trimester onwards, and not during cardiogenesis, which is usually before 10 weeks of fetal life. And the interventions that could be done for evolving hypoplastic left heart is fetal aortic valvoplasty or atrial septal interventions in terms of balloon angioplasty of the balloon dilation or stenting of the atrial communication. So to start with fetal aortic valvoplasty, so the natural history of any obstruction of the left ventricle outflow tract early in fetal life would be LV hypertrophy. Sorry, there's a typo there, which then obviously causes LV dysfunction and poor cardiac output, which then impairs LV compliance and feeling. And because of reduced flow and growth stimulus by flow, you have poor growth of the mitral valve, aortic valve, and the LV as a whole. And by late trimester, you see evolving hypoplastic left heart syndrome. The other response to outflow tract obstruction is over time with prolonged pressure load, the heart can also dilate, and there's lots of EFE, and you get a really dilated LV with poor function. So selection criteria is really important in terms of who you would target to do fetal intervention to have a chance in influencing postnatal outcomes. So you're actually looking to see which heart will progress to hypoplastic left heart and which subset of this are then salvageable with the intervention that you're doing. So overall, you are seeking a group with severe, bad enough disease to warrant a fetal intervention because it is not without risk. You have about 10% fetal demise rate. But the severity of this evolving hypoplast has to be not so severe that there's no hope then of ameliorating outcome after the intervention. So I've put some diagrams there. Sorry, I have to apologize at the start. All the images I've put in this presentation are still images because I don't want it to get stuck in the middle of the presentation. So for some of you who haven't come across fetal intervention, it is done via the maternal abdomen, as you can see in the diagram there. So generally now, you can do with the mums just awake or under some sedation. So under ultrasound guidance, obviously you put a needle through the maternal abdomen, through the uterus, and then through the fetal LV. So on the other ultrasound diagram, you can see that this is a fetal 5-chamber view. We generally put a 19 to 21 gauge needle, puncturing the LV just under the aortic valve, as you can see then. And then you would insert the wire and usually a coronary balloon through the needle, and it's inflated across the aortic valve. So quite a crude procedure, and I will present some outcomes of it later. So the next procedure is fetal atrial intervention. So we all know that intact or highly restrictive atrial septum is the largest risk factor for early mortality. Happens in about 5–10% of hypoplasts, and the natural history with this restrictive septum is you get significant LA pulmonary vein hypertension and pulmonary lymphangiectasia. And the survival is pretty dismal in this group. So survival at 1, 6, and 12 months in neonates with highly restrictive or intact atrial septum, despite undergoing postnatal balloon atrial septostomy, is 50%, 42%, and 30% at a year. And this is in comparison to our usual normal risk hypoplast, where your survival is 70%. So this gives the rationale for earlier intervention in fetal life or diagnose atrial restriction, and the thought is whether earlier intervention could change the postnatal disease severity. So again, looking at the diagram, you can see the fetal heart there, the right and left atrium that's been labeled there for you. I don't know if you can see it clearly. And positioning of the atrial stent, so this bright structure there between the atrial septum. So prior to the stent, this is the pulmonary vein Doppler. So you can see significant flow reversal. So the big spike that's going upwards is flow reversal into the pulmonary vein because of restrictive septum. And post-stent, you can see that the spike has really dampened down and there's nice biphasic flow in the pulmonary vein in the right direction. And equally in this paper, they publish a method to do direct LA pressure wire, and you see a reduction in the LA pressure from 25 mean to, I think, around 10 or so mean pressure. So what are the outcomes of this fetal intervention? So fetal aortic valvuloplasty is by far the commonest fetal cardiac intervention that's been done with the largest experience. There are a few single-center studies and some multiple center studies, and Boston and Linz are actually the centers with the largest experience. So I've tried to summarize the data on the outcomes. There are multiple papers, but I picked those with the largest experience and multi-center. And in the Boston experience, they've gone through several iterations of selection for fetal aortic valvuloplasty, and their latest publication is this, where they looked at a total of 123 fetal aortic valvuloplasty that they've done in a 15-year period between the 2000 and 2015. So you see the earlier cohort had 71 patients, and the later cohort had 52 patients. So that demonstrated an improvement in technical success from 73% in the earlier era to 94%. So generally quite a good success rate, even from the earlier era. And they've demonstrated a reduction in procedural mortality from 8% to 4%. And this is to do obviously with the learning curve, which we'll touch more about later on. And interestingly, they found an increase in biventricular circulation post this fetal intervention of around 59% in their latest era. Then we look at European data. So this is data from a working group of AEPC, looking at 6 centers. They had 67 patients. And the technical success rate, if you compare with the Boston group, is generally similar in the high 80s, even 90 mark. And the overall biventricular outcome seems slightly lower, 36%. However, when you scrutinize the data, you see that one center actually contributed about 50% of the cases. And in this center in particular, there's a 55% biventricular repair rate. So that just again goes to show that higher volume centers seems to achieve a better outcome. So from this, you would think actually maybe fetal cardiac intervention, aortic valvuloplasty may change outcome in 55% or about 50% of the cohort that had this fetal intervention. However, you get then conflicting information from natural history study. So this is an interesting study from, again, a multi-center sort of European data. They look at 107 fetuses with evolving hypoplastic left heart syndrome that's never had fetal cardiac intervention. So they use the same selection criteria that Boston used to select patients for fetal cardiac intervention, and they looked at these patients and what their outcome is. And they found that there's a 38% of biventricular outcome despite not having any fetal intervention. So this is similar to the overall BIV outcome in the multi-center European study. So does fetal intervention really help? So whilst I was in sick kids, I came across all this intervention, and we sort of looked at all the outcomes and reviewed it. And we came to a few conclusions about why there's such differences in outcomes in fetal aortic intervention. And I think the first thing to say is really the impact of volume and the large experience in single centers, but worldwide, small numbers in each center. So from the technical aspect, there is a learning curve for any procedure. And that's proven from the data that I've just shown you, where BIV outcome seems to be better from larger single centers. There's also a significant limitation in the selection criteria, in that it is very variable among different centers, And people have refined the selection criteria, so you're getting a very mixed group of patients who's had interventions at different stages of their fetal life. So the predictive models to date really lack adjustment for the gestational age and fetal weight, which has bearings on the outcomes of the fetal intervention as well as postnatal outcome. So one might think of it like if you have severe aortic stenosis earlier in gestation, it reflects a more severe disease process and has a lower probability of biventricular outcome, but the risk of fetal demise is higher. So if you intervene earlier, there's higher risk of the fetal dying, but there's also higher probability that you made a difference that could change postnatal outcome. And this is true conversely. So if you wait later so that you reduce the fetal demise rate, but the intervention that you've done at later gestation might be too late to make any difference to change any postnatal outcome. So then thirdly, whilst in a subset, the fetal aortic intervention may avert hypoplastic left heart syndrome, many patients are actually born with borderline hypoplastic LV, often associated with EFE, mitral valve hyperplasia or dysplasia. And these patients are then subjected to heterogeneity in postnatal management, institutional preferences to whether they should go to the single V pathway or the bi-V pathway, or they would go through a multi-stage LV rehabilitation. And finally, looking as a group as a whole, you'd think that in some patients, has there been irreversible myocardial damage that has occurred that cannot be reversed but by whatever we do in fetal life. So I think the verdict is still out there, and we can only know by doing more patients, standardizing selection criteria, standardizing postnatal outcomes, and reviewing and innovating every step of the way. So I think similar outcomes with fetal atrial interventions. I don't want to bore you with all the details, but essentially this is the largest study looking at outcomes of hypoplastic left heart patients who's had atrial septoplasty or atrial stents put in fetal life. So 47 of those. And you see again, technical success is quite high, 77%. However, again, there's no difference at discharge between those cohort that had fetal intervention and those that didn't. And those patients with, as we said, highly restrictive and intact septum, their survival is pretty dismal. However, as part of the study, they did look at some secondary outcomes, and they found some positive association with fetal atrial interventions in that you manage to stabilize the neonate better at delivery. There's a reduced rate of C-section, which is obviously good for the moms, and decreased rates of immediate postnatal interventions or neonatal resuscitation that's needed. So, I don't want to belabor the point, but I think, all the outcomes that we've looked at, is really biased by the small numbers that we have, and any beneficial effect are confounded by heterogeneity in the postnatal management that we've talked about. But one point to really think about is the impact of volume on outcomes. So even with the largest experience in Boston, you see that they're only doing 8 procedures per year over 15 years. So whilst the relationship between volume and outcome is not directly causal, I don't think it is also not completely independent, but there is a definite learning curve on any procedures. So recently there have been a call for super specialization of all these fetal cardiac interventions that should be concentrated in higher volume centers who will be able to commit to provide services to standardize postnatal care and to have a seamless collaboration between fetal services and postnatal services. So I just want to move on now to hypoplastic left heart procedure. So, sorry, a hybrid procedure. So as you know, this involves the PDA stent and bilateral PA banding as an alternative to Norwood stage 1. So these are some angiograms where the asterisks are showing the PA bands that's been put on by the surgeons, and surgeons can sometimes put on a clip, at the proxima or the ostium of the branches to give us an idea of the landing zone of the PDA stent. And then for the PDA stent, we are provided with surgical access through the MPA. This is a long sheath going in, a wire probing into the duct, into descending aorta, which is usually straightforward with such a large duct. So the stent is being deployed here, and you could use either balloon expandable stent or self-expandable stents. The key to this procedure is obviously not to cause retrograde obstruction to the retrograde arch, as you can see in diagram B, and that's the result of the PDA stent that's inserted. So you still see good retrograde flow into the arch and good flow through the stent to the descending aorta. So why the hybrid procedure? I think I presented data earlier on, the static outcomes of the Norwood palliation. This is another paper that's, supporting the evidence. So this is data from the Children's Hospital of Philadelphia, who again has a huge, case volume load of hypoplas and Norwood procedure. And they reviewed the outcomes, their 30 years outcome on, 1,600 Norwood, and came to the conclusion that perhaps, despite all the dramatic, improvements in surgical techniques, in, post-operative care, things might have plateaued in the last, 15 years. So the, average immediate sort of mortality has remained around the 10 to 15% mark. So the hybrid procedure is really introduced as a paradigm shift, perhaps a platform for learning and innovating to see if improvements can be made in managing these patients with hypoplas. So the hybrid procedure was first conceived by Gibbs et al. At Leeds, and then the early adopters were the Geeson group, and then a large group in Columbus, Ohio, Toronto, Sao Paulo, and now used across the world. So again, there are multiple publications now on the hybrid approach, and I thought I would present data on obviously the largest experience. So the group in Germany, they looked at all their patients, 182 patients whom they've done a hybrid stage 1 procedure on. And in this center, they would perform hybrid procedure on all hypoplastic left heart syndrome. So it's an unselected population. Median follow-up in this paper was 4.6 years. And you can see that they've achieved, really excellent results. Their operative mortality post-hybrid stage 1 is 2.5%, slightly higher the comprehensive stage 2 procedure, and 0. And most of their cohort went on to complete the Fontan. Interstage mortality remains the same. I think this is probably to do with the patient characteristics that we're dealing with, and really good predicted survival at 10 years of age. So these are a few graphs from their paper demonstrating their survival curves, and you can see survival at 1 year 80%, at predicted survival at 10 years. Again, 80%, and they've analyzed, different patient cohorts, those that we would deem of higher risk, aortic atresia and mitral atresia, and the probability of survival is actually similar. So again, to summarize, I think looking at all the outcomes there from different centers, there's no doubt that the 1 year survival of hybrid stage 1 is comparable to conventional Norwood palliation. And in fact, in centers with larger experience, the survival is slightly better. However, there is a higher mortality at the comprehensive stage 2 procedure because it is obviously a large undertaking in terms of surgery, and I'm sure Ramesh will touch on it next week. There is, however, similar interstage mortality, whether hybrid or Norwood palliation, but the intermediate survivor, again, I think is comparable. So what are the pros and cons of hybrid procedure? So the pros is obviously, hybrid is less invasive, it's an off-pump procedure, it's less acute post-procedural hospital costs, and the biggest pro is really preserving the brain, really, the neurodevelopmental advantage that's been shown for hybrid procedure compared to those who had Norwood stage 1 in the neonatal period. What are the cons then of hybrid procedure? So the main complications are really branch pulmonary artery stenosis from the PA bands. Significant rate, I would say. I mean, in the literature, is about 10 to 17% rate of retrograde aortic arch obstruction. And the PDA then complicating aortic arch reconstruction when you come to the comprehensive stage 2. Again, with this intervention, there is an impact of volume on the outcomes and how we manage the patients after the hybrid procedure. And there's a learning curve, not just for the hybrid procedure, but also for the comprehensive stage 2 that impacts on mortality. So a few groups around the world have been quite creative with this hybrid concept, so what we call modified hybrid approaches. So I think this is from data from Nationwide Hospital. So they've tended to use this modified hybrid approaches for patients with mitral aortic atresia, whom, from fetal brain MRI, their brain maturity is 4 weeks behind the usual cohort of hypoplastic without mitral or aortic atresia. So they would use they would band the children and leave the children on prostatin for 6 weeks, allow time for brain maturation, pulmonary vasculature maturation. And also the 6 weeks is sort of a sweet spot where they felt that they could take off the band easily whilst preserving the pulmonary artery size. So then the stage 2 is really the Norwood stage 1, where they would then do the Norwood Seno procedure and remove the bands. And the stage 3 procedure is the usual Glenn, and stage 4 is the Fontan completion. And then taking this to another extreme, this is a paper from Japan, who has actually used the hybrid for their higher risk patients, where they would put a PA band on and they would keep the patient on prostatin until stage 2 Glenn. Looking at the paper, they didn't really exactly mention why they would keep someone on prostatin for such a long period of time, but they did mention in the discussion that it was for easier arch reconstruction at later stage without the PDA stent. But looking at their cohort in this group of patients compared to conventional Norwood palliation, the patients did have earlier Glenn after Norwood stage 1, so about 3 months compared to 6 months compared to 6 months in the Norwood population. But obviously, I'm sure it's all running through your minds now, all the cons of, being on prostatin infusion long-term, all the side effects of prostatin and hospitalization. So I think there are many indications to using the hybrid in the current time. It could be used as a bridge to recovery or decision, which is really, and high-risk patients, which is what we're using it for. So this is to allow us to salvage poor hemodynamics, maybe allow cardiac recovery, or allow comorbid states to improve. So risk factors such as prematurity, low weight, NEC, any intracranial hemorrhages, renal dysfunction. So allow time for recovery until obviously the conventional Norwood or comprehensive stage 2 operation. Sometimes it's used for stabilization for non-cardiac procedure, for example, patients with congenital diaphragmatic hernia. And the last point is slightly controversial, but in some studies, there's been discussion about doing the hybrid to allow parents to make decisions. So these are patients, who present later, no antenatal diagnosis, whether this would be something that, we would undertake just to allow parents to come to terms with the diagnosis and whether they would want to proceed on with, univentricular palliation. I mean, this is food for thought, and, we all have our preferences. The other thing, under indications are bridge to biventricular repair. So I know that in a lot of centers, certainly in Toronto, when you have borderline left ventricle, mitral valve hyperplasia, you would proceed to a hybrid procedure to see if the LV or the left heart structures would grow, and then come back in a couple of months' time, have another MRI and re-evaluate your pathway, whether this child is for single or biventricular route. And obviously, as a salvage procedure, the hybrid can also be used as a bridge to heart transplant. So in summary, I think we have to open our paradigm to using hybrid for different indications and not just high risk babies. But obviously, volume plays a significant role on the outcome. Certainly out there in the publications that equivalent outcomes to Norwood in all the experience centers. And for them, it's not a question of whether to use it, but when best to use it. There are challenges with the comprehensive stage 2 procedure. Is extremely difficult, large surgery, steep learning curve for low volume centers, and some centers may never get over this learning curve. So it's really about evolving to tailor the treatments that we have for different individuals and different subsets of hypoplastic left heart syndrome. So, sorry, I need to go back. So those are my thoughts on the more innovative treatments. Now I'll move on to the more supportive treatments. And this is a nice review, not such a high impact journal in one of the polished journals, but actually quite a nice review of all the interventions that are complementary to the conventional pathway. So you could have a look at that. So as you can see, mainly, to do with opening the atrial septum and dealing with, residual lesions after the Norwood operation. So mainly stenting, ballooning of, shunts and PA stenosis, aortic arch obstruction. And then these are procedures after the gland operation. Again, similar procedures for obstruction in PA on the gland, for occlusion of venous collaterals. And then there are also a group of interventions for post-Fontan. Again, similar in terms of relieving any obstruction. And then you have those with failing Fontans where you can open up fenestrations, or those with significant right to left shunt and managing well, then you can close the fenestration. So a lot of things that we can do interventionally to help these patients along. So I just wanted to finish with a few examples. Since Oleg has asked me to show some Angio Imaging, I have to comply with that. So this is a 9-day-old infant with 3.1 kilo post-Norwood Sano, persistent desaturation in the 60s despite medical therapy, oxygen, nitric. So child was brought to the Cath Lab, and you can see a stenosis, so more like a folding, where it's opposing the sternum of the proximal Sano shunt. And usually you would be able to approach the Sano shunt through the venous route into the ventricle itself. But interestingly, in this case, it was extremely difficult going through the venous route into the RV. So a retrograde aortic route was used, so into the DKS, into the RV, and then through the Sano shunt. And you can see a nice stent has been implanted, and post-stent is unobstructed flow through the Sano, and obviously a good response with saturation. The other place where Sano shunt can become stenotic is at the distal portion. So this is a caudal view of the branch pulmonary arteries that you can see and that's the sano shunt. Don't know if you can see my arrow here as I'm moving it. But anyways, this is the sano shunt, and you can see very tight distal stenosis there. And again, a stent's been placed there, and you see opening up of the distal sano. This is a nice case of complete LPA occlusion post Glenn, and this is a 3D rotational angiogram that we did in the Cath Lab, and I think it rivals Fu's MR or CT. You get really nice reconstruction, not just of the vessels that you're imaging, but you can also see the airways and the adjacent structure. And here you see that's the nominate vein to the SVC RPA, and you see this continuation of the vessel into the LPA, and there's a small collateral supplying the distal LPA. So we could superimpose this 3D reconstruction from the rotational angiogram onto live fluoroscopy. And through the IJXS, you went in, the usual, try and cannulate the occluded vessel, bit by bit balloon dilation, and putting a sheath that would carry a stent and opening up this distal obstruction. So a really nice result afterwards. Atrial stenting is done not frequently. This is a patient who has recurrent restriction of the atrial septum post-Glenn, which I'm sure will never happen here. So you could put in, and this septum are usually quite thick and not amenable to septoplasty. So you can actually put an atrial stent in, and we usually leave it in a dibolo configuration, because of obviously the risk of embolization. And it works quite well, and the stent can be removed easily at the time of the next operation. This is a 13-year-old boy, again very interesting, who is post Fontan, who came in with a resting saturation in the high 80s and had significant desaturation on exercise and reduced exercise tolerance. So on angio in the SVC, you see a huge, massive, significant veno-venous collateral. And I apologize again that I don't have any, moving images, but this is the best still that I could pick. So it's actually coming from the junction of the subclavian vein and right IJ, and it takes a really tortuous course. I think this still image doesn't do justice to the tortuosity of the initial point of the collateral. And this is some MR imaging. So the vessel goes all the way down, and then it inserts to the right upper pulmonary vein. So we tried to cannulate from the top multiple times, durable catheters, but couldn't get wire position distal enough to deploy the occluder to occlude this. So we brought the child back at a different setting. And this time what we did was we went through the Fontan conduit, perforate through the Fontan conduit into the atrium, went in through the right upper pulmonary vein, and we occluded the collateral in a retrograde fashion. So here you can see that's the right upper pulmonary vein with deployed an occluder there, and blocked off the venous collateral. So child did have improvement in saturation, and then I left sick kids after, but I hear that Lee has brought him back for another catheter to again attempt occlusion on the top end because he's worried about thrombus propagation. Fontan fenestration closure, again, we close it for indications of low sets or reduce even more significant reduction in sets during exercise, risk of to reduce the risk of paradoxical emboli, and really to avoid anticoagulation, because some centers would put patients with Fontan fenestration on warfarin. So this is something that we would commonly do: search for the fenestration and put a ASD occluder in. I think that most of the examples that in sort of day-to-day life, and then I just like to finish with some other really interesting catheter techniques that I think has the potential to develop and is food for thought for us who are interested. So there have been case series, obviously in dire circumstances and in adults of transcatheter Fontan completion. So this is an example of closed chest transcatheter gland anastomosis. Sorry, so at the moment, imaging is a big advantage for intervention in that, you could see things in 3D, you could print out 3D model and, simulate your procedure before the intervention. So this was a 35-year-old woman from their case report who thing was extremely sinus. But anyway, a high risk for surgical glands. So they put a stent in the SVC as a landing zone, and then they perforated from the SVC into the right pulmonary artery, and they used a snare as a target for the perforation, and then they deployed another stent anchoring on the first stent into the RPA, as you can see in the angios, with really nice result. I should have shown this before. So this is a similar group. So you see the evolvement of doing research in animal models and using it in patient population. So this same group had actually looked at how they could do a transcatheter gland anastomosis in pig models, and they've innovated the current stents. So they flat out the distal portion of the stent so that it gives a secure anchorage between the PA and the SVC, and got really nice results from that. And that's, at post-mortem of the animal models, where you see the stent going from the SVC into the pulmonary arteries. And that's the flare end of the stents that you can see nicely anchoring the stent in the SVC. And then I think this would be a last slide for me. So there are also, a few case reports on transcatheter Fontan completion in humans now. So this is a 15-year-old with DILV VA discordance who's had 6 sternotomies in the past. His last procedure being a failed Fontan completion, which then had to be converted to hemifontan at about 4 years old. Over time, he seemed to have improved with medical management. PA pressure had reduced, and they felt that he was suitable for Fontan completion. But due to the complex surgical history, a transcatheter route was attempted. So you can see that they customized and made a really long CP stent and cannulate top from bottom, perforated through, and made almost like a Fontan conduit in the atrium into the IVC. And there's also been previous lots of animal models attempting to, innovate on possibility of transcatheter Fontan completion. But I think looking at, what's been published so far, the major limitations are really the technical risks. So, risk of perforation, in the wrong place, basically, that would, obviously, it's a higher risk compared to conventional surgery. And then the major limitation is also the devices that we have, what's the potential of 2-directional growth that you need for the stents. There's also the issue of, thrombus formation within the stent, intimal proliferation. And really for any Fontan conduit that we put in, you need to have nice flow dynamics. And, that's really not been demonstrated in the animal models of putting stents in for Fontan completion so far. So with that, I think I would end and welcome any questions from you all.
Thank you, Lang. It's exceptional presentation, I think, and we all benefit from this. Any questions from the floor?
Lang, Ramesh here.
Hi.
Fantastic presentation. I mean, very comprehensive, covered everything from kind of the evolution and the roles and the role of the interventional team. And I think the overall message it seemed to be was that the management of these high-risk patients is very much a team effort. That there's a big surgical component, but there's a massive interventional component as well. that provide the best outcome for these kids. From my side, I mean, some of the points regarding the Gießen and nationwide teams. Now they are almost evangelical about how they treat their patients with the hybrid approach. The only thing that has always kind of never sat comfortably with me and a lot of the surgical teams is the fact that apart from these two units and pockets here and there, no one else has made it standard of care in their management of the hypoclass. Which maybe they are ahead of the curve, or on review of some of the data, the feeling has been that they maybe push patients towards a hybrid approach as opposed to a standard surgical approach. And if you look at hard criteria such as maybe the Rhodes score, which isn't perfect, or the 2V score for bivent versus single ventricle repair, they might not hit all those criteria when they head down that route. So that's always been a slight criticism of the hybrid approach in my experience.
Correct. I mean, I agree with that completely, Ramesh. Their population is completely unselected, and I think there's a degree of being comfortable in the procedure, therefore pushing for the procedure, and generating the outcomes from that. So I think for the rest of the centers who don't do a lot of these hybrid procedures, we do need to think about the indications of doing that, and what our learning curve is. And I'm sure you touched on the comprehensive stage 2. So that is the other biggest thing. So even if you sail through the hybrid procedure, what happens at comprehensive stage 2 procedure? And as you were saying, is a whole center, whole team approach in terms of standardizing and improving cares for different procedures that we do.
Yeah, no, actually, that's very true. Excellent presentation again. Thanks.
Thanks.
Yeah, I'll just add on to the same thing. I spoke to Chetan a few days ago about the same hypoplastic left heart and hybrid. He said they've done 6 and 5 of them died before the Fontan. So as Leng and Ramesh suggested, we choose the very, very high-risk patients and then do the procedure on them. So that is one which we need to decide what for the future.
There was a question from Anand Wak, it's consultant from ICU. What is Audehe vision about hybrid procedure?
Sorry, what is all the vision about hybrid procedure?
Yeah, so I think this question is for surgeons and for interventionists as well.
I think we're very much driven by surgeons. Ramesh, what is your vision here?
I think it's a tricky one, and I don't think we're going to switch our view overnight. I think we will remain selective. The Nord procedure is tried and tested with good result in a very high-risk population. At the moment, yes, I agree, we do use it selectively in our highest risk population, so we're never going to show fantastic results. But I think we would need further strong evidence from units that are maybe not as evangelical about it. And a staged, and I agree. I mean, I think part of the progress is maybe adopting it in slightly higher risk and moving forward. So it's always, I think, as a unit, personally, we will probably always stay quite selective unless there is overwhelming evidence that it is better.
Yeah, I think, Ramesh, one cohort that personally I feel we could utilize more on is the borderline left ventricle. So, if there's doubts, about, suitability or adequacy of the LV, there's perhaps a role in, the hybrid procedure to breach and to evaluate, the growth of the left heart structures before we decide on the pathway. This is, obviously not hypoplastic per se, but, in the borderline left ventricle. I don't know what your thoughts are on that.
No, I think it's a very good point. And I think traditionally the view has been you go down the Norwood route and then potentially consider converting to a 2V repair later, which is in itself a huge operation as well. So a good point, and I think something that we will consider over the next couple of years.
Yeah, brilliant.
Another question from me, Len. What do you think? Shall we go first for intervention if we have got some geometrical problems with Glenn and Fontaines before surgical correction? Does it work?
So increasingly, when you look at, I mean, as part of this, I was listening to some presentation from, the larger US centers, and they're actually advocating hybrid procedures. And I feel this is probably the way, collaboration in the future. So if you think that the child has hypoplastic, PAs, plan a hybrid procedure, place an LPA stent, balloon dilation at the point of the, gland or Fontan, which I think we're already doing in some cases. I don't know if that answered your question. Was that your question?
Yeah, I mean post-Glenn, for example, if there is any geometrical problem, so would you consider to go first with stents, or it should be redone by surgeons?
Oh, obviously, if you ask any intervention, we would like to give it a go, and because as we recently encountered, a case, any redo stenotomy is a risk and it's difficult. So if there's anything that we feel interventionally might help, we'd be inclined to, ask to attempt in the Cath Lab for balloon angioplasty or stent implantation. Obviously, in growing children, stent implantation is not an issue, but it does subject the child to further interventions in the future in terms of having to redilate the stent to accommodate somatic growth. There's also the question of what kind of anticoagulation or antiplatelet therapy the child has to be on, but these are, I would say, minor issues in the grand scheme of things.
Yeah, thank you so much. Any other questions to the Lang? Well, thank you, Lang. It was really, really a good presentation, and we had 20 attendees today, so I think it's highest number of listeners.
Thank
So
you.
it's quite
Thank you for participating.
a success. Yeah. Thank you very much for
Perfect.
everyone.
Bye. Have a good day.
See you next Wednesday. Bye bye.
Bye.